In the chapter Schizophrenia, under the subcategory of Psychological Treatment and Management of Schizophrenia, we encounter the study that is Sensky et al. In this study, they tried to compare the efficiency of one-to-one CBT, cognitive behavioral therapy, and a befriending intervention for people with schizophrenia. The sample consisted of 90 16 to 60-year-old participants with schizophrenia who were diagnosed using ICD and also DSM, and they were randomly allocated into two groups. One was the CBT group, and then the other was the befriending group. All had been prescribed a daily dose of at least 300 milligrams of chlorpromazine of a minimum of 6 months, but they also still experienced positive symptoms. Treatment was delivered by 2 experienced nurses who received regular supervision, and also symptoms were assessed by 2 individual blind raters, and they were assessed before the treatment started to establish as a baseline, and then post-treatment, which was up to 9 months later, and then also 9 months later after the treatment had ended, which was the follow-up period. So let's look at the 2 different conditions in this experiment. There was the CBT sessions in which the therapist worked collaboratively with the patients to understand the development of both positive and negative symptoms and to reduce distress and disability. And then in the case of the befriending, which would serve as the control group, obviously, they received the same amount of contact time with the therapist at similarly paced intervals, so this would form a sort of control. And then the therapists were empathetic but non-directive, and they talked about hobbies, sports, and current affairs instead of CBT sessions. And the different CBT techniques that were used to treat different symptoms in Sensky were, when it was the symptom of hearing voices, the patients were asked to document their experiences in diaries and also to critically analyze the client's beliefs about the origin and nature of the voice to help them devise coping strategies for those specific symptoms. And then there was delusions. Guided discovery using Socratic questioning to help them challenge what their irrational beliefs are, and then they would do this using probing questions. They would ask them to present evidence for whatever claims that they're having, and these claims would be delusions. It would be that they have some kind of belief that's not rooted in reality. And then this downward arrow technique was used to explore subjective meaning of the client's thoughts to reveal any sort of underlying beliefs or basically interpretations that they may have of something that really did happen, but it's their interpretation that led to the delusion. Then in the case of disorganized thinking, therapists also can use the technique of thought linkage when they are having scattered thoughts, which is repeatedly asking the patient to explain the connections between the 2 thoughts that are not very likely to be mentioned together normally, and then they would kind of teach them how to connect those dots. Negative symptoms is essentially the symptoms that are supposed to be present in a normal individual, but it is not present in someone who has schizophrenia. So in this case, strategies including paced activity scheduling would be ideal to minimize the fatigue and stress that a person will go through, which will end up with them developing more negative symptoms. And also, clients are again encouraged to keep a diary of the times that they felt pleasure and a sense of accomplishment to help them stay rooted in reality and also for them to not lose trust. The results were that participants attended an average of 19 sessions in 9 months. Regardless of the condition, both experimental and control experienced this. There was no significant difference in the number of sessions attended by the CBT group compared with the befriending group. Both groups showed a reduction in post-treatment symptoms, but only the CBT group showed this continued improvement at the 9-month follow-up assessment. There was also no difference in medication use between these groups, as that would serve as a control. In terms of conclusion, CBT is shown to be more effective than befriending, as seen in the results. Patients continued to improve post-treatment follow-up, unlike befriending, that is after the entire CBT sessions have stopped taking place. And then initial improvements were no longer evident at the follow-up in the case of the control group, which was the comparison that they had set. When we're evaluating Sensky, we have to account for the fact that they had a blind rater that randomly selected the sample of tapes to assess the quality of treatment. So this would allow them to avoid subjectivity or bias when it comes to the rater not knowing which condition the participant belonged to. And also, this would essentially improve internal validity, as the rater was able to check that the befriending sessions did not contain elements of CBT, and CBT sessions covered all expected elements. A strength of the sample in terms of generalizability was that it was selected from 5 clinical services in London, Newcastle, Cleveland, Durham, and UK, which means that there is a greater confidence as the sample included people living in a variety of urban and more rural locations. Since they used a drug to kind of make the controlled situation where both groups were taking the drug, that would mean that this study does not actually prove whether CBT would be effective for this on its own, but rather combined with drug treatment, it is efficient. As it turned out, initially, the participants were not responding to their medications, but they were still taking them, and over a period of time, it was possibly the combination of the drugs and the effects of the CBT that caused their condition to improve. A final weakness is the longitudinal design. Because some of the participants were excluded due to not completing a sufficient number of therapy sessions, 6 of them failed to engage at all and 9 dropped out before they had received sufficient therapy. The dropout rate would cause loss of data, and that loss of data would reduce validity. And there's also the additional context that some of the people who had dropped out had a shared characteristic. So it could very well be that CBT may not actually help every single subset, but maybe it's more oriented towards a subset of people that have coherent speech, for example, where some people do not. And that is all for Sensky.